Hi, everyone. On behalf of the CLL Society, I'm Alan Skarbnik from Novant Health, and I'm here to interview Dr. Jennifer Woyach on a very interesting abstract, abstract 4622 LP168, Rocbrutinib, a novel covalent and non-covalent next-generation inhibitor of Bruton's tyrosine kinase, updates on the phase 1 trial and initial results of the CLL gatekeeper mutation cohort. So, Jennifer, thank you for participating in the interview. This is a very, very innovative concept. Can you talk to us about the study?
Yeah, thank you. Hi, I'm Jennifer Woyach from The Ohio State University. This was a really exciting phase 1 first-in-human clinical trial of LP168, now known as Rocbrutinib. So Rocbrutinib is a new version of a Bruton's tyrosine kinase or BTK inhibitor that actually has dual function. So in the presence of wild-type BTK, it can bind covalently or irreversibly, just like ibrutinib, acalabrutinib, and zanubrutinib all bind. What's interesting about this molecule, though, is that in the setting of a C481S mutation in BTK, so the mutation that commonly can cause resistance to those covalent BTK inhibitors, Rocbrutinib can actually bind reversibly in that setting. And as well, with this reversible binding and the irreversible binding, it was predicted structurally to be able to inhibit BTK not only in the presence of the C481S mutation, but also in the presence of T474I mutations, which can drive resistance to non-covalent BTK inhibitors like pirtobrutinib. So in this study, we've treated about a little bit less than 40 CLL patients, and it was a very heavily pretreated patient population. Of course, many of the patients on the trial had received a covalent BTK inhibitor and even a non-covalent BTK inhibitor and venetoclax. The initial dose finding is complete with 300 milligrams currently being thought of as the phase 2 dose, although probably further dose optimization is going to be needed in subsequent studies. But for patients who received what we think of as the more therapeutic dosing, the response rate was over 70%. And importantly, we had a number of patients who had the T474I gatekeeper mutation, and they also had a response rate that mirrored what we saw with the entire patient cohort. Now we do have data where patients are approaching 3 years of treatment, and the drug seems to be very durable in this setting, with many patients over a year of treatment, a number approaching 3 years of treatment. This is a very selective BTK inhibitor, so actually has been very well tolerated too. And we've seen very low, or I think maybe 0 patients with atrial fibrillation, and seen low rates of hypertension. Bruising, of course, has been seen, and then some other things that are sort of typical to CLL studies, like upper respiratory infections and things like that. So overall, I think it's a very exciting new molecule, and we look forward to further studies both in this setting and then hopefully combination studies too.
There's a really cool concept. I imagine most patients have received a covalent BTK inhibitor before, right?
All of the patients.
All of them. Yeah, it's very interesting, this dual effect. I mean, it's how the drug can block one, and if that's not blockable, go to the other kind of the mutated part. It's very, very interesting. Do you think that, I know it's like all the data for this is still cooking, but you know, at this point, if you had a BTK degrader in your hand or something like this in your hand, where do you feel this will go?
You know, I do think that it is appealing to try to kind of maximize the BTK inhibitors potentially before the BTK degraders, because you should be able to use a BTK degrader after a drug like this. So I can see it really in 2 fashions. Like one, maybe post-COVID or post-non-covalent BTK inhibitors, maybe prior to a degrader, but also with the potent covalent inhibition and the selectivity of the drug, I think it's actually really appealing to study even earlier in treatment, maybe even in the frontline setting by itself, or really maybe preferably with a combination partner.
That sounds phenomenal. Remember us when this trial is going on and actually participate.
Absolutely.
Sounds like a good drug. Well, thank you very much, and hope to see you soon.
Thank you.
Thank you. All right, that's actually really cool drug.
It
Really,
is a cool drug, yeah.
really cool. All right, let's go to the next one is the the discontinuation one. That's also great data from you guys. 700 something. The guy has too many patients.
Yeah,
So
you
impressive.
know. Let me look at the data really quick first. I can't
Sure,
remember all
go
the
for it.
numbers. Um, okay.
You good?
Yes, I'm good.
All right, I'm gonna start again. Editors, this is where we start. Hi, I'm Alan Skarbnik on behalf of the CLL Society. I'm from Novant Health Cancer Institute, and I'm here to interview Dr. Jennifer Woyach, post-ASH, talking about one of the studies that she is a co-author on, the senior author on that study. It's about outcomes of patients with CLL discontinuing Bruton tyrosine kinase inhibitors due to adverse effects. That's abstract number 4629. Very important data set, Jennifer, me, something that we always question, those patients that we need to stop the BTK inhibitors, which are very potent, fantastic drugs for CLL, but unfortunately can carry some side effects. What we do with them, right? I mean, do we go jump to another treatment, or can we hold? And this is a question that has, I think all of us who treat CLL have struggled many times with. So tell us about your findings.
So thank you very much. I'm Jennifer Woyach from the Ohio State University. So we looked at all of our patients that were treated at Ohio State. The study was authored primarily by Dr. Anthony Mansour, who's a resident at Ohio State. So we looked at all of our patients who had been treated with covalent BTK inhibitors, specifically focusing just because of the time frame on ibrutinib and acalabrutinib, and then looked to see what happened when patients discontinued due to adverse events. So we had a total of over 700 patients in entirety. And of these, about 20% discontinued therapy due to adverse events. We ended up grouping ibrutinib and acalabrutinib together because we actually just had a lot more patients on ibrutinib. And so our models were not as stable when we looked specifically at acalabrutinib. But overall, the data looked similar. So we're combined together. So about 20% in total discontinued. And we saw a median progression-free survival from the time of discontinuation of 21 months. So on average, it was almost 2 years before people needed another therapy. When we looked at factors that contributed to that progression-free survival, we saw that lines of therapy, so patients in the frontline setting tended to have a longer remission duration. Patients who were on their treatment longer had a longer remission duration. And those that had, it actually was not very different depending on prognostic factors otherwise. So overall, I think the takeaway from a study like this is that when we have a patient who discontinues a BTK inhibitor for toxicity, we don't need to jump to switching them to a different therapy right away. Really, I think that was something that we had done initially as a field because we were worried about flare when we discontinued a BTK inhibitor. That doesn't seem to really happen in the setting, especially of people who have not had multiple lines of therapy before, but especially in people who have a good remission at the time when you discontinue treatment. So instead of going directly from one drug to another, stopping therapy, and then monitoring for progression. Because for these patients, again, who are especially in the frontline setting, who had been on the treatment for a while, it could be years before they need additional therapy.
So your data is showing that it does make a difference how long those patients were, like 2 years was the cutoff,
Yes.
right?
Yeah.
It was continue beyond 2 years or earlier than 2 years. You know, we know that a number of the side effects are very front loaded, like the diarrhea tends to happen early on, and nausea, rash as well. I mean, some, of course, hypertension, atrial fibrillation increase over time. And there are some patients, unfortunately, we have to stop the drug, right? Even if it's early within the first 6 to 12
Mhm.
months of treatment. So based on this is a patient you would be more inclined to go into another treatment kind of right away rather than waiting, even if the disease is somewhat controlled, or I mean, I know it's case by case, but
Mhm.
in general, it's something that you feel still comfortable waiting until there's a progression that will require treatment at time of discontinuation.
Yeah, I mean, I'm interested in your approach as well, but I think certainly I would monitor them more closely, like maybe even get weekly labs if it's somebody who really had been on less than a year, especially if they still have some gross residual disease. I would probably, I do in clinical practice still just discontinue and watch though, because I've been surprised sometimes at people who got very little therapy with a BTK inhibitor and still have a pretty good remission duration. I don't know how you tend to practice.
Yeah, I think I mean if the disease is controlled, I feel more comfortable. I'll still follow them closely
Mhm.
because we've seen sometimes because that the initial data back when it came out, we had that oh, people who discontinued ibrutinib, the overall survival is poor. I mean mostly was from progression at that time, and those were heavily pretreated patients. So think it's different than our current reality where most of these patients are receiving drug in first, at most second
Mhm.
line. So I think that paradigm has changed quite considerably. Nowadays, I feel more comfortable waiting. I think it truly depends on how the disease is controlled and
Mhm.
also patients' level of anxiety, right? There's some patients who really don't want to, I mean, we started treatment and a few months later we had to stop. They really want to go back on it. We have fortunately other options. I mean, lots of times you can switch from one BTK to one. And this is another thing too. I mean, the data set is largely with the ibrutinib where the rates of discontinuation are higher.
Mhm.
Um, and at this point, most of my patients who are on ibrutinib were kind of legacy. They've been on it for a long time.
Mhm.
Wasn't a recent start. I think that most of us are starting with the second generation BTK inhibitors, where the rates of discontinuation are lower. This is fortunately a problem we see less and less. But I'm with you on those lines. I think that if the disease is controlled and we have reliability on monitoring the patient, they're not going to go for a year without seeing us. They'll, they'll come in a
Yeah.
few months. I feel comfortable waiting. I'm with you there.
Yeah.
Okay, well, great data set. I mean, more and more information for us to make good decisions for a patient. Thank you so much.
Thank you.
Okay, thank you. I think that was it.
Yeah, thank you. That was great.
Short and sweet. Thank you
Yep.
so much. I hope to see you soon. We have to talk about bosses some time if that study will ever
Oh, I know.
start. You know,
Yeah. Yes.
just
Hopefully well.
hopefully soon.
Yeah.
We're going to start hopefully soon to start at our site. Talk soon.
Yeah.
Have a good
All right.
day.
See you later. Bye-bye.
Bye.